Hello to another community meeting during the PrEP month, which we just launched after the Cyprus PrEP Point launch on the 29th of May. The Cyprus PrEP Point is a community information and empowerment center providing information, support, and guidance to everybody who is using PrEP in Cyprus. Regardless of the fact that it's not yet officially available. We hope that it will be soon after the announcement that it was approved by the minister. The plan that was submitted for official access to PrEP was approved by the minister. So today we have with us Dr. Vyacheslav Grankov. I hope I said it correctly, Slava. Welcome.
Thank you. It's correct, yes.
So Slava is representing WHO office, a regional office in Europe. And today he's going to talk to us about the role of HIV PrEP in HIV and STI prevention and how to put WHO guidance into practice. And after we finish with the presentation, there will be a Q&A follow-up. So let's begin. The floor is yours.
Thank you. Thank you very much, Kostas. So I'm very grateful to the organizers for inviting me and sharing some of the most recent WHO recommendations regarding PrEP. And also, I will talk a little bit about upcoming guidance as well. So I will start sharing my presentation. So I hope that you can see now my presentation and
yes.
In my presentation, I will talk a little bit about evidence regarding PrEP, about WHO recommendations on PrEP, what is in pipeline, and of course, I will talk a little bit about context of WHO European region. We know that globally the number of new HIV infection is decreasing and also related number of AIDS deaths around the globe. But unfortunately, if we are talking about WHO European region, which includes 53 member states, including Eastern Europe, Central Asia, Central Europe, Western Europe, unfortunately, the number of new estimated number of new HIV infections is not decreasing the same way as it decreasing globally. And there are estimations that the number of HIV-related deaths are actually increasing. And in this regard, prevention is very important and would play crucial role in terms of decreasing both number of new HIV infections and in future number of HIV-related deaths. And among prevention methods, there are methods that are linked to antiretroviral drugs, and it's PrEP and PEP. I will not talk today a lot about PEP. I will just mention that we are talking about post-exposure prophylaxis. It's when antiretroviral drugs are used by people who do not have HIV, but they were exposed to HIV. PEP, according to WHO guidelines, should be offered as early as possible to individuals with suspected or known exposure to HIV, ideally within 24 hours, but not later than 72 hours after exposure. And it's usually 3 RVs taken for 28 days. And what is very important new addition in recent guidelines for HIV PEP, it's that HIV PEP should be delivered in community settings. And now we are coming to PrEP, which is a key part of combination HIV prevention. And PrEP is started prior to a potential exposure. And it's not, of course, lifelong and can be started, stopped, then restarted if needed. And it's very empowering tool with psychological benefits. But we need to remember that PrEP does not protect against other STIs or pregnancy and other prevention methods. For example, condoms should be used in combination with PrEP in order to prevent, for example, getting STIs. And since the beginning of PrEP era, we can see that there have been many, many different studies. Some of them are presented on these slides that proven the effectiveness and safety of pre-exposure prophylaxis. And based on these emerging guidelines, WHO developing a lot of different recommendations, and these recommendations were evolving together with new emerging evidence. And most recent evidence was coming from so-called Purpose 1 and Purpose 2 studies. I will talk about them a bit later. And if we look at different studies, I will not talk a lot about it, but I'm just showing that all these studies showed a really significant effect and which allowed WHO and other organizations to provide strong recommendations regarding PrEP, pre-exposure prophylaxis. And if we look at the package of interventions recommended for key populations, they are written in 2022 Consolidated Guidelines on HIV, Viral Hepatitis, and STI Prevention, Diagnosis, Treatment, Care for key populations. We see that HIV PrEP is recommended for all 5 key populations: men who have sex with men, people who inject drugs, transgender people, sex workers, and prisoners. And we live now in an era of PrEP options. We have oral PrEP, tenofovir-based. We have dapivirine vaginal ring, and we have long-acting injectables, cabotegravir currently recommended, and very soon, just we are living in a few weeks before, WHO will recommend lenacapavir as one option for HIV pre-exposure prophylaxis. But unfortunately, all these options has not become a real choice for people in our region. And currently, if we look at WHO recommendation, as I mentioned, it's a strong recommendation because we have high certainty evidence. Oral pre-exposure prophylaxis containing tenofovir should be offered as an additional prevention choice for people at substantial risk of HIV infection as part of combination HIV prevention approaches. And if we look at criteria for initiation of PrEP, we need a confirmed HIV negative status, absence of signs and symptoms of acute HIV infection, and substantial risk of HIV. But you see here clearly that WHO also indicates that individuals requesting PrEP should be given priority to be offered PrEP, since requesting PrEP likely indicates there is a risk of acquiring HIV. And that's why conversations should be focused on achieving sexual health and HIV prevention goals and be gain-framed, not risk-framed. Because still in many Asians and countries, national guidelines often require specific risky situations in the past in order to be eligible for getting PrEP. And WHO said that even people who do not want, for some reasons, discuss their risk behavior, but they request PrEP, they should be given priority. And possible future exposure should be a greater focus than past exposure when we are assessing eligibility for PrEP. So depending on several factors, we can prescribe PrEP in two dosing regimens, depending on individuals' characteristics, circumstances, and route of exposure. So for cisgender women, trans and other gender diverse people assigned female at birth, transgender women and other gender diverse people assigned male at birth but taking extragenous gender affirming hormones, and people who inject drugs, they should start PrEP with 7 days of everyday PrEP, then you continue PrEP with 1 dose each day for as long as protection is needed, it's desired, and then you see that stopping PrEP also for 7 days after last potential exposure. For other groups, for people who are assigned male at birth and with sexual exposure and who are not taking gender affirming hormones, it's a bit simpler. We can start, you can see, with 2 tablets at 2 doses, 2 or 24 hours prior to the first exposure. Continue with 1 dose per day for as long as oral PrEP is desired, and stop by taking 1 dose per day for at least 2 days after the last potential exposure. Regarding dapivirine vaginal ring, it should be inserted 24 hours prior to potential exposure, and it should be worn continuously in the vagina. It can be for 28 days. And after 28 days, it's recommended to replace with a new ring or use another prevention option as protection rapidly drops. Unfortunately, this dapivirine vaginal ring is not very present currently in Europe, but it is recommended by WHO. Another recommendation of WHO is cabotegravir long-acting PrEP. You see here 2 trials that showed very important results. Relative risk reduction in HIV infections compared to oral PrEP was very significant, 66% and 88%. And so we know that even oral PrEP is effective, but this cabotegravir long-acting was even more effective in terms of reduction of new HIV infection. And systematic review and meta-analysis showed that combined effect, it's 79% relative risk reduction. And it's mainly this additional effect compared to oral PrEP is related probably to high adherence to cabotegravir long-acting PrEP. You see that the studies, adherence to long-acting PrEP was much higher than oral PrEP. And actually, it's one of the advantages of long-acting PrEP, because it's an injection. It's people because when oral PrEP, people can forget taking their daily doses. It's much more difficult to ensure full adherence. And based on the results on these studies, and WHO issued guidelines in 2022, then long-acting injectable cabotegravir may be offered as an additional prevention choice for people at substantial risk of HIV infection as part of combination prevention. Oral PrEP is also highly effective, and cabotegravir long-acting should be offered as a choice alongside oral PrEP and dapivirine vaginal urine. And PrEP services provide an opportunity for integration with other services. We should always remember that it's contraception, STI, and other. But also we need to remember that long-acting feature of cabotegravir is both its greatest strength, but it's a challenge also to implementation. And the main challenge, it's very long pharmacokinetic tail. So you see the median time from the last injection to the time when cabotegravir concentration decreased below the lower limit for quantification. And it's almost 44 weeks for male participants, and even more, 67 weeks for female participants after last injection. So, and it's of course creates potential risk of drug resistance because, as you can imagine, the concentration remain, but it's not the concentration not high enough to prevent new infection. So, as a result, we can develop a drug resistance in HIV, and we understand that cabotegravir resistance to cabotegravir can limit the use of other integrase inhibitors of the same group of the medicine, for example, dolutegravir, which is used widely for the treatment of HIV. That's why it's very important to monitor to have always strategies of stopping cabotegravir. Regarding lenacapavir, it's a absolutely new class of antiretrovirals. It's capsid inhibitor, and I mentioned already that two purpose 1 and purpose 2 studies already showed the very high effectiveness. Purpose 1 study showed that lenacapavir was 100% effective in HIV prevention among women, and purpose 2 showed that lenacapavir reduced the risk of HIV 96% compared to background HIV incident. And lenacapavir was 89% more effective than oral PrEP. It's among MSM. And based on these results, currently we are waiting for the release of WHO guidance on lenacapavir. It's embargoed currently and will be launched on 19th of July. And of course, we will be working with all of you on implementation of these guidelines to make sure that lenacapavir will become available across our region for HIV prevention. But also this year, there were results of pharmacokinetic study was shown that currently lenacapavir will be recommended for one subcutaneous injection every 6 months as a prevention. But here in this study, subcutaneous injections twice yearly were compared with once yearly intramuscular lenacapavir injection. And what is very interesting, and you can see on this slide, that median plasma concentration after once yearly intramuscular injection exceeded those associated with efficacy in studies of twice yearly subcutaneous lenacapavir. So these data show the potential for HIV prevention with 1 yearly dosing interval. It's amazing. We already even 1 injections every half year is amazing, but if it will be once yearly dosing, it's very close to actually vaccine-like prevention. And we know that some population-level studies show that it's not only effective for individuals who are taking PrEP, but PrEP scale-up is also associated with decreases in new HIV infections in populations. And we have here examples of many examples in England, Australia, in Scotland, and there are similar results. There are unfortunately some myths that PrEP can cause STI rise, because there is assumption that since people are taking PrEP, they do not use condoms, and it can lead to increase in STIs. While these concerns are possible, of course, and there are some studies that are showing some increase in STI, but in fact, STI rates were rising years before PrEP, and condomless sex was increasing years before PrEP. You can see that, for example, new STI diagnosis among MSM in England, and you can see here HIV, syphilis, gonorrhea, chlamydia, and you see near 2014 when the 15, 16, when PrEP was actually started implementing, and STI diagnosis, number of STI cases were rising many years before. And it's in Victoria State in Australia, you see it's chlamydia. You see the year when they started scaling up PrEP, and we see that the rise of chlamydia cases started and was continuous for many years before PrEP. The same about gonorrhea, syphilis. So we need to understand that there are some behavioral changes in key populations regarding including sexual risk and condomless sex, and we need to take it into account. So we regard PrEP as a way to get access to populations with highest STI risks. So we are not saying that PrEP increases STI rates. We are saying that PrEP services are a gateway for STI, for integrating STI services for people with the highest risk of STI. And I will not stop here, but just to mention that it's very important that in our regional action plans for HIV, STIs, and hepatitis for WHO European region, we have strategic direction on HIV and prevention of the transmission of HIV with a particular focus on key populations. They are one of their priorities. And we have even targets for 2025 and 2030, how many people should receive PrEP at least once during the year. And unfortunately, so far, we are not reaching these targets. And if we look at about global number of people who received PrEP in 2019, 2023, so of course the overall number of users is increasing, and more than 3.5 million people are receiving PrEP in 2023. But over 75% of them, they were in African region, while if you look at the Euro region, the number of PrEP users were not increasing as fast as in some other regions. And majority of PrEP users are MSM. It's understandable, but at the same time, we need to make sure that other groups, other key populations have equal access to PrEP, and it should be, of course, incorporated in national guidelines for PrEP. So when we are talking about slow uptake of PrEP in the region, we are always thinking why it's happening, whether it's availability or it's accessibility, acceptability, maybe including the access to different products and options, whether it's costs, problem with lack of funding, implementation issues, but we always say that it's very important, first of all, to create more enabling environment and reduce stigma, discrimination, and of course, decriminalize in countries where we still see criminalization of both HIV exposure and transmission, and also of population. And we, as WHO, we are conducting program reviews in countries. And we also, during these reviews, look at the PrEP implementations. And unfortunately, PrEP is still provided as pilot projects, mainly among MSM, and number of PrEP clients is very limited. PrEP services is highly medicalized, requiring excessive clinical monitoring. And as I mentioned earlier, in many countries, indications for PrEP include specific risky situations that potentially limit the number of clients who can be enrolled and benefit from PrEP. Also, in many countries, requirement to provide passport data is one of the barriers, especially when there is high level of stigma and discrimination towards key population. And of course, we still have insufficient awareness and misconceptions of PrEP among target populations, and low knowledge and PrEP among providers, which can, of course, affect retention and continuation. WHO 2022 updated guidelines and introduced so-called differentiated and simplified pre-exposure prophylaxis to make PrEP services more acceptable and accessible, with simplified approach to assessing kidney functions, and HIV self-testing mentioned as one of their possible testing strategies for PrEP. And differentiated PrEP service delivery approaches should be person and community centered, and adapt services to the needs and preferences of people who are interested and could benefit from PrEP. It can be delivered at primary healthcare settings, community settings, it can be virtual settings, and can be given by physicians, nurses, pharmacists, or peers. And service packages, as I mentioned, should integrate STIs, viral hepatitis, vaccination, and other services. And I will give you just examples how in many countries, so I would say successful stories of PrEP implementation. For example, in South Africa, which PrEP is currently available in 95% of primary public health facilities. And you can see when they started public health, public sector scale up PrEP 2019, how number of PrEP clients increased. And we see now that PrEP initiations, it's 1.6 million PrEP initiations, 95% at the primary healthcare facilities. It's great achievement, of course. It provides, of course, population level results, HIV prevention. Or, for example, São Paulo, and they started using mobile application that operates every day from 6 to 10 p.m. through teleconsultation. So people do not need to go physically to the doctor. They can do it online, and then they can be delivered via special machines or at special points. But unfortunately, when ECDC assessed HIV stigma in healthcare settings, and one of the questions was about PrEP, knowledge of PrEP among healthcare workers. And you see that, unfortunately, there is still very low level of knowledge on PrEP among workers. Only 41% knew that someone who does not have HIV can take HIV medicine to prevent them from getting HIV care. And you see the level of knowledge at primary healthcare centers was around 33%, and even lower in dental clinics, 22%. And the highest level was at the community centers. And if we look at the different parts of our region, so you see that the lowest level of knowledge was in Central Europe. So my final words regarding PrEP will be that PrEP is highly effective and safe. It is recommended for all people at significant risk of HIV. PrEP should be part of a comprehensive package of services for key population. And no good PrEP coverage in the country means no full-fledged prevention, and differentiated and demedicalized approach to providing simplified services can make PrEP services more acceptable and accessible, and promote PrEP coverage, adherence, and effective use. It is necessary to promote improved awareness of healthcare workers and all institutions about modern achievements of science and practice in the field of HIV. And we also need to think about a person taking PrEP as an example of responsible attitude to their health. It will help to, of course, to increase coverage with PrEP and PrEP access. So I will stop here. Thank you very much for your attention, and we'll answer your question if you have. Thank you.
Thank you very much. Before I stop the recording and we go into the Q&A section, a quick question on the first slide on PEP. Did you say that WHO is recommending that PEP is also provided in CBOs, community-based organizations and community settings?
Yes, exactly. So the most recent recommendation on PEP issued by WHO actually recommends that PEP should be also available at community centers and delivered through community. So it's possible and it's effective, and it should be one of the options. Yeah,
that's fantastic. So let me thank you very much for a comprehensive presentation and the important information you gave us. A special thanks to WHO Europe, not only because you are here, Slava, presenting this and participating in our PrEP month, but also because the criteria for individuals to be able to access PrEP that WHO put out is basically excluding no one. And I have to say that this was a strong argument from our part, from the community, when we were advocating for official access to PrEP in Cyprus, and in the discussions we had in the National AIDS Committee. And it was really important for us that there were these recommendations by WHO that was saying that anybody who requests for PrEP, regardless of who they are and regardless of their potential risk of HIV transmission, should be given priority. I think it's really important, and thank you for the work that you're doing and being so close to the community.
Thank you. Thank you.
So I'll switch off the recording so we can start our discussion.